This afternoon, we are looking at completing the equation with respect to antepartum hemorrhage. As of yesterday, we did look at a number of aspects of antepartum hemorrhage, ranging from definition to classification. Then we did look at other aspects of conditions of antepartum hemorrhage which we don't usually concentrate on. And we looked at the uterine rupture and the vasa previa. Then we narrowed down on the placenta previa and placenta abruptio, where for both conditions we compared and contrasted. Starting from definition, we went to pathogenesis. Thereafter, we looked at classification, further going down to symptoms, signs, differential diagnosis, complications. I think that's where we ended. Now, allow me to re-emphasize on the part of complications. Generally, we say that placenta previa is not harsh on the baby, but placenta abruptio is harsh on the baby. So almost always in placenta previa, the baby is fine unless the bleeding is just excessive, that it has compromised the maternal circulation and therefore overwhelmed the baby's compensatory mechanisms. But it's very rare to have fetal distress in placenta previa. But on the other hand, you find that for placenta abruptio, almost always there's fetal distress or IUFD because of complete detachment of the connection between the mother's blood supply and the baby. So that is obvious also. Now, let me mention something that I was almost concluding with yesterday on the part of placental abruptio. Because again, remember, placental abruptio, we said it leads to coagulopathy, what we call consumptive coagulopathy, because it overwhelms the clotting factors and they will be consumed, they will diminish, and therefore it will bring the DIC closer. In addition to the dead fetus releasing tissue thromboplastin, and in addition to the primary etiology, which would have been preeclampsia, for instance. So it becomes a serious vicious cycle. Now, one other thing is, if you remember very well, we said both previa and abruptio can lead to prerenal hypovolemia. Not so? And lead to acute kidney injury. But for abruptio, in addition to just prerenal hypovolemia, AKI will arise from acute tubular necrosis. That explains why, when you are looking at an abruptio patient, don't just look at bleeding. Yes, red substance can panic, make people jump, but you should not just look at achieving hemostasis. You should also be interested in the fate of the kidneys. So an abruptio should always have fluid, and I will emphasize fluid, fluid, fluid. If you call me, Dr. Man, and you tell me, you claim that the patient has placental abruptio, and I find only one canule, notwithstanding the fact that the patient is fully conscious, I will not take you seriously. A placental abruptio is an emergency. You should have 2 IV access, as we shall discuss in the management, and you should have fluid running at all times. Because what kidneys want is continuous perfusion. You create dehydration, you create hypovolemia, acute tubular necrosis will celebrate. And I can tell you from my limited experience, almost always, of all the complications of preeclampsia, the one which will make the patient land on the hemodialysis almost permanently will be placental abruptio. So if you find this patient has kidneys that have been shut, meaning they failed to reverse, and ultimately will require hemodialysis, you'll find that the patient will tell you they had placental abruptio. All these other things of HELP syndrome, mention them. They can be reversed after delivery and after you do appropriate management. But I always worry about one complication out of all of them. That is placenta abruption. So I just thought of emphasizing the point. So now let me go to management. So you have the notes, you don't need to write, but I'll be writing very quickly. So we had previa on one side and we had abruption. What are the issues with placenta previa? Before you commit yourself to managing the patient, even as a medical student, what were we told? If a patient is broad, sorry, not a patient, if a question is broad, somebody just wakes up and say, what's the management of placenta previa? Don't say it's cesarean section. Neither should you say vaginal delivery, because the question is broad, not so. If you say previa should be managed by CS, people will tell you that is incorrect. If you say it is vaginal, they'll say it's incorrect. Then which is correct? So if a question is broad, you also start by giving a blanket statement. So here, management of placenta previa depends on, what does it depend on? Number one is gestational age. Number two is hemodynamic instability or status. Number three, it will be the type. So management will depend on these three. So whenever you've got a case of placental previa, ask yourself, what's the gestational age? How stable is this patient hemodynamically, and what type of previa? So that your management will vary. So let me put a statement here to say, if patient is okay, let's start with gestational age. Gestational age is less than 38. 1, is hemodynamically stable. 2, and the type is, okay, regardless. Here, let's put regardless of the type. Then we will need to set a delivery plan. So in the notes, I should think I gave you all the aspects. So the first thing is obviously admit, IV access, at least 16 or 14G or 18, 16G, whichever. Number 3, we say that IV access should be present at all times. Next, we are going to do investigations. I almost skipped the investigations, but let me mention it at this point, because you are admitting the patient. So we're just looking at management, which is investigations and treatment. So which investigations are going to do for placenta previa? There are just 3. The first one is full blood count. Second one, grouping and cross-match. Again, something special about placenta previa. It's not just grouping and cross-match, but we say group and keep. There's a word keep. Cross-matched. It's only used in placenta previa with respect to obstetrics. What grouping and keeping cross-matched means 2 things. It means that you should have at least 2 units of blood present in the ward where the patient is. Not at the lab, not at blood bank, but in the ward at all times. Now, blood expires after some time. So it means after they see the expiry dates, they can actually get those 2 units, take them back, and get a fresh sample. Meaning those which are about to expire, they can give them for the emergencies of that day. So that's what we mean. So it's about where you place the blood, and also how you will be taking back and getting the more fresher units. So you group and keep cross-match. That was the second one also. The third one is an obstetric ultrasound, because an obstetric ultrasound will confirm the diagnosis of placenta previa 1, and 2, it will give us the type, based on what we discussed in terms of the types. So you've done the investigations, you've admitted the patient. IV access at all times. What else are you going to do? You will need to, obviously, start the patient on some medications. So immediately, you start the patient on steroids. And we know that the glucocorticoids we use in terms of enhancing fetal lung maturity is dexamethasone, usually, but you also have a choice of betamethasone. I think Dr. Piri discussed those aspects, including other advantages of steroids in a premature baby to be, should we deliver earlier, such as reducing the risk of intraventricular hemorrhage and necrotizing enterocolitis. So we need to give the steroids. Next, we need to start the patient on hematinics. So the hematinics we give normally is folic acid and ferrous sulfate. I don't know whether Dr. Munyo, you know that, no, not Dr. Munyo. You know that the folic acid we give is too high. That 5 milligram OD is too high. And I think I mentioned that we only use such high doses for sickle cell disease and for diabetes mellitus. But we need just something like 400 micrograms. And we know that folic acid and ferrous sulfate, particularly ferrous sulfate, will require vitamin C as well for its good absorption from the intestines. So I think all those aspects and dosages have been included in your notes. Then, what else do we need? Don't forget she's an antenatal mother. Therefore, at some point she will need tetanus, she will need deworming, she will need Fancida for IPT, she will need everything else any expectant mother benefits from. Because many at times when a patient has been admitted with the PPROM, with the APH, you find people have forgotten that she's an antenatal mother, busy looking at the one condition and forgetting that she is an antenatal mother who needs to benefit from the full package of antenatal care, both in terms of medications and investigations, meaning DCT, hepatitis B, mention RBS, mention blood group, and the rest. Next, away from medications is we need to look at monitoring. What are you going to monitor? The nurse should monitor vitals. They should monitor for PV bleeding. How will they know that this patient is bleeding or not? They need to do what is called pad count and inspection. So she should request the patient to not discard the pads that they are using with respect to making her comfortable with the vaginal bleeding, if at all it's there, but keep those pads so that the midwife or nurse actually inspects and sees, okay, 3 pads, are they fully soaked? Are they partially soaked? Because if you are just going by the number, you might be misled. A patient can tell you, I've changed maybe 8 pads. What will that give you? You might think this patient is bleeding actively, let's even deliver immediately. Yet, maybe it's not even significant bleeding. Obviously, in addition to knowing whether it's fully soaked and the number, you also need to look at the type of bleeding. Is it fresh blood or not? Away from that, what else will the midwife do? Obviously, they will also monitor for possible preterm labor, meaning uterine contractions, because that becomes an emergency. And also, they will need to monitor for the fetal heart rate, in addition to probably kick chart and other methods of assessment of fetal well-being. The other thing that you need to quickly emphasize in placenta previa is that digital vaginal examination or any form of vaginal examination is highly contraindicated. So no one should do that. Again, in terms of midwifery care, people should avoid unnecessary aggressive palpation. There are some people who palpate aggressively. I don't know how you palpate, Dr. Mutai. I haven't seen you yet. But me, I've seen people who squeeze the abdomen when palpating. I'm looking for where the head is and where the leg is, and the toes, I can't feel them. Now imagine you are doing that. You are traumatizing the patient. Then, away from monitoring, we need to look at subsequent follow-ups. What are we going to be following up? We'll be following up 2 important parameters. The first one is full blood count. The second one is obstetric ultrasound. So this should be done 2 weekly. Why are we doing them 2 weekly? So your aim, let me start with full blood count, is you aim to have the HB above 11 grams per deciliter at all times. That's one. Number 2, is that for obstetric ultrasound, yes, we know it's a placenta previa, but why should we continue monitoring? Yes, the placenta sometimes can move out of the way. Remember where we are coming from. We said that the bleeding in placenta previa, which makes it painless, fresh, and also unpredictable, is that the placenta is fixed, the lower uterine segment is moving. So there's shearing. Now, instead of shearing, sometimes you might be lucky the placenta will fall. That explains why, if somebody has a low-lying placenta, let's say before 28 to 32 weeks, I would not panic a lot, especially if it's an anterior, because the lower uterine segment normally closes anterior, from the anterior aspect. So it can move the placenta with it. And it's not uncommon to find a low-lying placenta later on becoming funded. And you drop the diagnosis of placenta previa as time goes by. So what do we call that? We call it placental migration. Away from checking for placental migration, it could be that you also want to look at the estimated fetal weight and other parameters that you normally look for on ultrasound. Then, if you are in an advanced center, like where Dr. Piri comes from, I know where she comes from, her village. Those people even can do fetal lung maturity tests. So they can do this sphingomyelin ratio, phosphatidylglycerol, lamellar body count, and other things. Because you cannot just guess to say, no, let's deliver tomorrow this patient. I mean, what is your basis? Because I thought your main worry with a premature baby is breathing, not so. So if you can do objective fetal lung maturity test, then you even know that, okay, the LS ratio is above 2, it's now 3:1, I think we are comfortable. Based on this and parameter, I think this baby is okay being outside the womb of the man. Then we now talk about timing of delivery. We deliver at 38 completed weeks. And in terms of mode of delivery, it goes back to what I was talking about. The type of previa. So if it's type 1 and type 2A, those are minor. You can do an experiment. I normally call it an experiment because sometimes it can be a waste of time. You can do an experiment and await for labor onset. Because when the labor starts, the cervix will start dilating and effacing. So probably it will be 2 centimeters, 3 centimeters. Then you take the patient to theater. In that theater, you do what is called EIT. So on the consent form, the patient will sign for EIT plus or minus CS. What does that mean? What that means is that you have what is called a double set arrangement. So we'll be like me and Dr. Tamara, we will be like the examiners. So we'll put the patient in lithotomy without necessarily having anesthesia, just an examination in lithotomy, so the two of us. Then Dr. Mwandama, who is the nephew to a renowned physician, hematologist, Dr. Piri, Dr. Mtad, you be scrapped, you even put on gowns and gloves, of course, with the theater nurse, and the set is open. That's how serious it is. And the anesthetist will be on standby with what is called rapid sequence induction. For those who still remember what we used to call the one arm brain circulation. Okay, rapid sequencing, because we might need to quickly knock off the patient should anything happen. So what will happen is that the ones who are examining, the first thing they will do is, this is the cervix. You go in to do a vaginal examination, but you go in the fornices first. Now, it takes experience to be able to palpate through the roof of the fornices. From the posterior, the lateral, you check. There is what is called a boggy sensation, which can make you feel there is a placenta around the margins of the endocervical canal. And at that point you say, we suspect there is a placenta, let us proceed with cesarean. If you think there is no placenta by that external examination, then you now do an examination within the endo-cervical canal. Almost like the way you do the sweeping of the membranes. You can feel that I cannot feel the placenta. At that point, you rupture the membranes, take the patient into the bowel for possible augmentation and aiming for vaginal delivery. So that is called the EIT. Now, in the process of doing your experiments, imagine me and Dr. Tamara, we are doing a non-academic experiment. And then we poke into the placenta and it starts pouring like a tap. It's not us now to say, doctor, let's go and scrub. Sister, where's the set? Those people, Dr. Mwandama, who is a physician, Dr. P, those would have already scrubbed. So, anesthetist will just convert into GA, rapid sequencing. These would have already started the swabbing and the turbinate on skin. And within minutes, baby will be out. Clear? Yes. So that is the EIT. But if you know that it's a major placenta preview, why should you do that? Just proceed. So usually EIT comes in when there is an element of doubt. You are not so sure. Are we still dealing with minor or major? But in my practice, I've only seen EIT being done once, and my teacher has told me, don't waste time. Make a decision. Are you going to do a CS or not? So in most cases, you find people will just go straight for cesarean section without necessarily doing EIT. But it will remain an academic question as you teach your medical students in terms of the double set theater and the EIT. Then the issue now is, how do you approach such a cesarean section? You have a placenta which is anterior, low lying, and yet you always do the cesarean section in the lower segment. Do you go through the placenta? Do you avoid the placenta? Do you do a classic cesarean section where you just open from the fundus? That's how a classic cesarean section is done. You cut a bit from behind, like that. Almost, but longitudinal. There's a reason why you cut longitudinal and not, because here that's where the placenta is. So do we open from the fundus and deliver the baby as breech so that we don't traumatize the placenta? That's option number one. Number two, do we open the uterus, do a scrotum incision, and put your fingers in such a way that you bypass the margin of the placenta before you extract the baby? There is a way in which you can do that, because usually where the placenta is, you see blood vessels, because this placenta has been invading by trophoblastic waves. So it is getting as closer to the serosa as possible. So you can tell that this is where the placenta is. So somewhat you can avoid it if you so wish. Or if you are fast at doing cesarean section, as fast as Dr. Damdoch is faster than me, and she delivers in finishes Caesar in 7 minutes, me I take 45 minutes on average. So if you think you are fast, then go through, because if you will fidget with this placenta, there will be so much bleeding such that now there will be fetal anemia, and you end up compromising the neonatal outcome. So how you come up with those options is up to you. It will be based on your experience, your preference, and so on and so forth. But I can tell you, if you go through the placenta and find this woman obviously is not in labor, because you can't wait for labor if it's a major. Now imagine you find a floating head, meaning you go through the placenta and all you can touch is a bit of the head up there. What are you going to do? You ask for fundal pressure. Push from the top. Then the head is not even coming. It's like the head is even going back. What would be option? So in that case, because you've already opened, since you committed yourself to this, we now discourage people from making inverted T's. Please don't do this type of incision. There's so much weakness at the T junction. And therefore, we normally advise you do a J incision. This is a J incision. But don't go lateral to the round ligaments, because you end up meeting the uterine vessels. So you'd rather extend the J so that you try to get hold of the legs, or do some kind of internal podalic version. But If you want, you can do that. But we know once you do a classic, this lady needs to deliver by CS next time, even if it will be 1 CS. So these are big decisions to be made. And no wonder we can conclude by saying the senior-most surgeon should do that operation or should be present at the time of delivery for several reasons which we've seen. Because if you don't want to do an extended J incision, you might need to use forceps, like the Wrigley's outlet forceps, to grab the head and then pull it out through the incision. No wonder you find that some theaters, even in hospitals I've worked in, they always have obstetric forceps in theater for that purpose. Now, I'll conclude by saying that if the placenta is low-lying, it's anterior, low-lying and anterior, suspect placental accreta. Again, the need for a experienced surgeon to be in theater, because you can predict and ask your patient to sign for CS plus or minus hysterectomy. Because you know that if this placenta is stuck into the myometrium, why should you attempt to remove it when you know that it won't come out? So I've severally guided at various fora to say, don't tamper with a placenta you think is acretic. Already it's warning you to say, I'm anterior, I'm low-lying, I'm a previous Caesar. And if you can talk to our radiologist, he is very experienced, he can even do a low-frequency scan and be able to see how much deep the invasion is. He can tell you that this placenta has really invaded the myometrium. I think we suspect this could be a placental accreta. Of course, at postgraduate level, we even look at markers that we can